respiratory system is one of the largest systems. It is also one of the most dangerous systems. It is, as we've talked about, figuring out immediate life threats to our patients. What are the three systems that we immediately need to be concerned about?
Airway, breathing, and circulating.
Yep, what do we call this?
ABCs.
ABCs. So, respiratory system is going to be the breathing component and a little bit of the airway component. We're going to get into sort of where that breakdown is. Respiratory system, respiratory emergencies, it is the scariest to me. It is very scary for a lot of reasons. The reason why it terrifies me is because for these patients that are having these emergencies, they can be completely alert, oriented, they are aware that they are dying, and they can be dying right in front of you, they can be very well aware of it, and you can watch somebody die if you don't do anything, and so absolutely terrifying. This is one of the systems that I have studied the most because not only is it one of the most dangerous, it is also one of the most complex. And unfortunately, as EMTBs, you guys are going to come across this very frequently, and you guys are going to have close to no tools to be able to fix this. So that's what makes this even more complex. Looking at top 10 causes of death, chronic lower respiratory disease is I think it's like number 4, 5 since COVID hit. Top 10 causes of death. So this is something that where you're going to run into with pediatrics who are having asthma, and you are going to run into with elderly who have had these problems for 50, 60 years. So you're going to see this from a wide variety of types of patients. I was just talking to everybody about how scary respiratory diseases are. So let's get into it. So setting the stage, we're going to talk a little bit about A&P. We're going to talk about our assessments, figuring out the difference between respiratory distress, respiratory failure, respiratory arrest, and then we're going to start getting into specific diseases. And this is where it starts getting a little bit tricky. We are going to touch on some of the major diseases that are related to the respiratory system. But what I think is really important is that you can spend time studying all the specific diseases, which will come with time. But in the end, all of these specific diseases really kind of boil down to a couple core sets of symptoms that are going to be causing the respiratory distress or the respiratory failure. And we're going to talk about how even without understanding the specific disease that's affecting the patient, you can still recognize the symptoms and recognize what you need to do to counteract them. So talking about pathophysiology, specific conditions, and then we're going to talk a little bit about some of the medications you guys are going to have access to some degree, and what they do, how you use them, and then we'll talk a little bit about age-related variation. Like I said, there are going to be specific diseases that you're going to more see in pediatrics. There are other diseases you're going to see more in the elderly, but we'll talk about those. And then just general assessment and care guidelines. So, case study. EMTs Jake Pratt and Paul Berg arrive at residence to find a 62-year-old Margaret Brown sitting in the kitchen table, leaning forward on her hands to breathe. They immediately note that she is a thin woman with a barrel-shaped chest who's using accessory muscles to breathe. So, walking in, across the room, this is what you know. Is this patient sick or not sick? Sick. So what are some indications that she's sick?
She's using accessory muscles to breathe.
So what does that mean? What are accessory muscles?
Like her abs, or maybe her chest, or back, or obliques.
So what does that mean?
She's kind of
Labor breathing. But why is she needing to use accessory muscles?
her diaphragm is.
So yeah, if the diaphragm is tired or giving out, then you can be using accessory muscles. In the end, if the system is recognizing that the the way that the body is just, it's struggling to ventilate, oxygenate, so it's trying to use every resource it can in order to maximize. So what about leaning forward on hands to breathe? What's that? Anybody demonstrate what that would look like?
Leaning forward on hands to breathe.
Mm-hmm.
Kind of go.
Exactly. So you're gonna see, I mean, like, and you see it with, you know, after you run, you sprint, and you're the. So that's really kind of, we call it tripod position. What does that do? What's that doing for our bodies?
Kind of opens your lungs up.
It opens up your lungs, yeah. So so it sort of maximizes our lungs' ability to expand. So again, the body is recognizing that it's having issues either ventilating or oxygenating, and so it's trying to maximize both of those abilities. So it's trying to maximize the lungs' abilities to expand. What else? What else?
Barrel test is a big one.
So what does barrel chesting mean to you?
There's tension in her stomach, kind of big. Something's stopping it in her lungs, some disease, something's happening.
Close. Anybody else have anything they want to add? All right. So barrel chest, you can see it. The ribs and the intercostals are really sort of more expanded. It's really enlarged. That a lot of times we are going to see with chronic respiratory diseases. It's partially because the body has compensated to such a degree that it increases the masses to allow both better expansion and to sort of be able to push more air out. We'll get more into that a little bit later. So we know that this patient is sick. We know that her body is trying to compensate in various ways. So let's get into it. Despite an increased respiratory rate and increased work of breathing, Mrs. Brown's skin color is pink. Jake notices a portable oxygen concentrator as well as a nebulizer nearby. So what does all that say to us?
She's had this problem before.
She's had this problem before. What else?
Apparently it's chronic if she has all the medications that she needs.
Yep. So we've got the concentrator, we've got the nebulizers. We know this is kind of a chronic issue. What about so her skin color is pink? What does that mean to us?
She,
Not getting enough oxygen.
yeah, she's struggling.
What's that?
She's struggling to
So
breathe.
so what skin color what color should skin be?
Depending on what it is, probably whitish. Not completely white, but kind of like a darker white.
Well, so as a standard, we say skin color is pink is what we consider appropriate. So that used to be that, you know, we used to say skin color is warm, pink, and dry, and that was our standard for good. What we've more moved towards now is instead of saying skin color is pink, we say skin color is appropriate for ethnicity. I mean, if you have, you know, an African American and you can't say that skin color is pink, well, what do you say? Is it so? Now we say, you know, skin color is appropriate for ethnicity. But if somebody's saying skin color is pink, that means that generally the skin color is appropriate. So what does that tell us about how can the respiratory system affect skin color?
Hypoxia.
Hypoxia. So what can hypoxia do?
How about make your skin purple, blue? Maybe?
So blue, what's that called?
Cyanosis.
Cyanosis. Now here's the tricky thing. Bluish skin or cyanosis is very specific for not having enough oxygen in the tissue. You are not going to see, except for very rare circumstances, where the skin color is going to be bluish or cyanotic and there isn't an oxygenation issue. But just because the patient, you know, is having respiratory issues or is having oxygenation issues does not mean that the skin color is always going to be blue or cyanotic. I can tell you plenty of times we've shown up and, you know, a patient is in, you know, a heroin overdose, something like that. They're not breathing, you know, their O2 saturation is 60% and they're completely pink. But I can tell you that if I show up and I see a patient who's cyanotic, who's blue around the lips or blue in the face, I know immediately that they're having a respiratory problem. So pink does not mean everything is okay, but blue is definitely gonna tell you there's a oxygen problem. Does that make sense to everybody?
Like, not every pink patient is okay, but every blue patient is not okay.
Exactly.
Yeah.
So very specific, but not very sensitive.
Do you know what causes, the cyanosis, cyanosis, and like, why does the lack of oxygen create that differentiation in the color of the skin? Why is it blue, why is it?
So we could get into the chemistry, but right now I don't really think it would serve you.
It's deoxygenated blood. The
Oh,
oxygen that's circulating in your blood is what actually turns it red.
Okay.
When it's deoxygenated, it turns that blue color. Does that make sense?
That makes sense.
Is that an easy way to, layman's terms, kind of yes and no? Boy, if you don't sit down somewhere,
Yes, but
I don't wanna sidetrack you, it was just a
Yeah.
quick question, but if you wanna get into chemistry, I'll hear it, but I don't wanna sidetrack.
how about during break? We'll get into
Yeah,
it. 'Cause
we'll
what
get
actually
into it.
happens is the tissue actually breaks down other compounds, and we'll get into it. We know that skin color is pink. We know there's a chronic issue. So we see so what is a nebulizer? Does anybody know what a nebulizer is?
Too much, I don't forget words.
Try your best.
It's like a humidifier.
Yeah. So a nebulizer, it's a method to take sort of a liquid that generally is a medication, and it pushes air through it. It kind of aerosolizes the medication so that the patient can breathe it in. And so we see it a lot with medications that the patient needs to breathe in because they're having a respiratory issue. And so they need to get the medication down into their lungs. So, it'll come with, a little vial of liquid, you put it in a little machine that you hook up to a mask, blows the air through, it aerosolizes the medication so it can go down into the lungs. Otherwise, how are you gonna get medication down into the lungs? So if we see a nebulizer nearby, then that also tells us that this patient has been trying to take nebulized medications to try and help this. And if you're there, that means that that's not helping, which means this patient has a chronic problem that has recently gotten worse, which is what we call acute on chronic. They have a chronic problem, and then it acutely gets worse. You have asthma all your life. You have a chronic problem, and then you have an asthma attack. You have an asthma exacerbation. That's acute on chronic. So this patient had an acute on chronic event, and they've tried to use one of their medications, a nebulizer, to help, and it hasn't helped, and then you show up. So you know that some steps have already been taken to try and help this, and it hasn't helped, and then you show up. So you kind of know where you are in the progression. So what is your general impression of the patient so far? We've already talked. We know this patient's sick. What additional information will help you complete your general impression? So what does our general impression include?
Vital signs,
Vital signs.
ascertaining their level of awareness and
Mhm.
consciousness.
Mm-hmm.
You're noticing signs, kind of like stuff being barrel tested and stuff. Something like being barrel tested, kind of like emphysema, stuff like that.
So
You notice certain things, and you see other diseases, then you kind of can put it together in a list, see exactly what's wrong with them.
you're right, but also you're jumping from, because right now we're talking very general. You're right, you're actually on the right track, but also you're already down the hole of figuring out what the disease is and all sorts of stuff. You're absolutely right, but we gotta start with the general, our airway, our breathing, our circulation, our vital signs, immediate interventions, all that sort of stuff. So what immediate action should the EMTs take while completing the primary assessment?
Make sure the airway is open and
Sure,
there's
airway's
conscious
open.
air.
Mhm. And so if we've got a respiratory issue, what should one of our first thoughts be?
Make sure
What's-
there's an open
what-
airway.
Open airway, absolutely. What else? What interventions do we have?
Oxygen intake?
Oxygen. So, if she has a concentrator You know, maybe she's normally on oxygen and it broke. Maybe it's just not enough. And this is what's kind of interesting. And unfortunately, you know, what we're going to teach you is different from what we got taught 10 years ago. It's going to be different from what you guys are going to teach in 10 years. Is that the idea that you know, oxygen administration. You know, generally, yes, as a good rule of thumb, if you walk up on somebody who's having a respiratory issue, then you immediately should throw oxygen on them. And there's various ways to administer oxygen. Have you guys gone over those?
Yes.
One of them.
Okay. How can you administer oxygen?
Non-rebreather, nasal cannula, a CPAP, a couple of ways. That's all I know on the top of my head.
Are EMTBs able to start CPAP? That's terrifying.
It's in the national standard. I don't know if it happens here.
Okay. All right. So let's what is the lowest amount of oxygen, or what is the method we can give the patient the least amount of oxygen?
Is it a nasal cannula?
Nasal cannula.
It's
And
2 to 6 usually, right?
what's that?
2 to 6 liters a minute.
Yep, 2 to 6. Generally, though, keep in mind that, you know, once you get higher limits of, you know, closer to 6, it starts to be a little bit of heavy flow. So if you keep patients on that for a while, it can sort of bother them. They can say they can dry out their nares, all that sort of stuff. I mean, if I'm being perfectly honest, there are times you're gonna jam a nasal cannula up to 15. But yes, 2 to 6 is a standard for nasal cannula. And what about next step up?
Is it a non-rebreather?
Non-rebreather. And what do we put that at?
15, 10 to 15.
Yeah, 10 to 15. And so what patients do we put on a nasal cannula versus a non-rebreather?
I don't know the answer to that.
That's fine.
I mean, I would imagine that a non-rebreather would be more severe and.
Yeah.
Yeah.
Yeah, and I mean, if you're walking into a patient that's, the one thing that you don't want to do is put a patient on nasal cannula and then need to bump them up to a non-rebreather, because in the end, opening up a package and setting them up on something is going to take about a minute to 90 seconds. And sometimes, you know, that's time that you don't want to waste. If I've got a patient that I think is a respiratory, you know, issue, and I think I need to throw them on oxygen, it's easier just to throw them on a non-rebreather and then take them off if needed. So, you know, they say that, well, oxygen percentage-wise, room air is how much oxygen? 21%. And for every liter, how much percentage is going up? Anybody ideas? 3%. So if you put them on 1 liter, they're breathing 24. If you put them on 2 liters, 27, 3, 30%. That's just something that it's a cool little party trick that, you know, once you're a medic, will become useful when using other types of masks. But in the end, they say that non-rebreather at 15 liters, it's supposed to be about, you know, about 100%. In the end, it's not going to be perfect because, you know, you're going to have leaks and the patient isn't always going to be breathing straight from that. But nasal cannula, non-rebreather. Now, next step is what?
Could be a nebulizer.
Yes, but that's giving a medication. That's not to help with oxygenation. That's not giving oxygen. You give oxygen sort of as a side effect, as a byproduct, but that's not your. What's our next step up for giving more oxygen?
What do we use during CPR to give breath?
Bag? EDM.
So that's where we sort of take a little sidestep. So when we're giving oxygen, are we helping with oxygenation or ventilation? Oxygenation. The patient needs to be breathing on their own. If the patient is breathing, we can give the extra oxygen. They're going to breathe in the extra oxygen. Now, if they're not ventilating, if they're not taking the breaths themselves, you can give them all the oxygen you want. It's not going to do anything. It's not getting down in there. So that's when we start talking about how a respiratory system is kind of a divide between ventilation and oxygenation. So ventilation is a system, your diaphragm lowering, you're bringing in the actual content, whether it's oxygen, whether it's room air, and then the oxygenation is actually down in the lungs, the transfer of oxygen from the lungs into the bloodstream, and the transfer from the carbon dioxide into the lungs so it can then be breathed out. So nasal cannula, non-rebreather, that's if the patient's ventilating but not oxygenating well. And then a bag valve mask is if they're not ventilating. Now if they're not ventilating, they're obviously not oxygenating well. But you can still ventilate and not oxygenate well either. So it's kind of like you need to figure out whether it's an oxygenation issue, it's a ventilation issue. We'll get into all that in a second.
And are there any guidelines for the back valve mask in terms of the liters?
So that's always gonna be, 15
15
liters.
plus.
Yeah. Honestly, you just crank it and go.
Less than 8, you want to be bagging them. Greater than 24, you want to be bagging them. Is usually the standard.
Okay.
That's not the general rule. That is the
Word of mouth.
huh?
Is that like the word of mouth?
The street way of doing it?
Not necessarily street. Usually somebody who's breathing 24, if they can control their breathing, if you can coach them, talk to them, get them to slow their breathing down, you can forego the bagging part. But yeah, always less than 8, you need to be bagging.
All right, moving on with the case study. Sorry, I sort of got stepped away. So, respiratory distress is frightening and potentially life-threatening. Like I had said, it is scary because a patient, if they're strictly having a respiratory emergency, they will be possibly completely with it and staring you in the eyes as they're dying. And that sucks. It really sucks. You must be able to recognize signs and symptoms of respiratory distress and provide immediate intervention. And that's what we talked a little bit about, figuring out whether it's a ventilation or an oxygenation issue. We'll get into that. So, respiratory system consists of upper airway, lower airway, and the lungs. So, connect the upper airway, the lower airway, and the lungs to me. Tell me what parts are what. What's the upper airway?
Trying to think of medical terms.
If you don't have to do medical terms.
Your larynx, your
Trachea.
trachea.
So upper airways could be oropharynx, nasopharynx, pharynx in general. What's its job? What
To
does it
take
do?
in oxygen.
What's that?
To take in oxygen.
Taking oxygen, so it's the pathway down to the lungs. Does it do anything else?
Controls your airway. Controls how much you take in.
Yeah. It also provides humidification.
So it's not just dry air.
Right? Right, which then actually allows extra oxygen but anyways, it also filters out particles. So it it prevents anything from getting down into the lungs. Lower airway.
Would your alveoli be considered your lower airway or that lungs?
That's lungs.
Okay.
Like
So-
your bronchi and all that. So your-
Yep, bronchi, so as we all know, so it goes from trachea, and then you've got main stems, and just divides up to, I think it's like 32 times all in all it divides before you get down into the alveoli, where you actually have the gas exchange.
What is that called where they branch off into the left and the right? Anybody know that?
corona.
Piranha.
Corona.
Yes.
Oh, did you call it corona?
It is.
Yeah.
I will accept it
Yeah.
though. It's close.
100%. Yep, the corona. So normal breathing. So what is a normal breathing rate?
12 to 20.
12 to 20. That is a great guideline.
I've got a question about that.
Yeah, what's up?
My wife's an RN and she said they teach her 14 to 24.
So that's the thing. is
What's
that,
the-
12
is
to 20, 14 to 24,
I mean, it's kind of the same. but
Exactly.
it-
Yeah, and in the end, it's a great guideline, but if I have somebody who's breathing 11, if I have somebody who's breathing 22, I'm not gonna be like, that is inadequate respiratory rate. Everybody's a little bit different. It's all based on body size. Actually, it's really kind of based on how tall you are. But that's Yeah.
For your testing purposes, it is 12 to 20.
Yeah.
Okay.
So, 12 to 20 is going to be your, but as you, for pediatrics, is respiratory rate going, what's the amount of
Higher.
respiratory
It's
rate?
going higher.
Mhm. So what's, pediatric respiratory rate, what's considered normal?
Depends on the age.
Depends on the age. Mhm.
Fill out them cards. Why we made cards.
Infants is 30 to 60.
That's right.
School age child, 6 to 11 is 18 to 25.
Mhm.
Toddlers 22 to 37.
Mhm. So what I tend to do is that if you could remember that adults are 12 to 20 and infants are 30 to 60, just kind of know that, across the age, it's going to be somewhere between those. If they're closer to the infant, think closer to 30 to 60. I remember, in EMT school where I was like, well, a 4-year-old is supposed to be breathing, 26 to 44. That's great, but that's wasting up a lot of headspace. And it's like I've harped on before, it's very tough. This entire industry in the real world is a world of gray, and we're trying to give these black and white rules. But yes, 12 to 20 is a great starting point. That's going to be your answer on the tests. Okay. So patient age and medical history. If you have a patient with certain respiratory diseases where they have very large lungs, they might, or a history of fibrous lungs, they might naturally breathe at 26 times a minute, 30 times a minute, and that's their normal. But in the end, you are not going to have a patient with respiratory, issue, and their only abnormality, you're not going to be like, they said they were feeling completely fine, but their respiratory rate was 28, so I know they're having a life-threatening disease. You're going to look at this patient as a whole, and you're going to have multiple things pointing in one way. It's not like you're going to have one weird abnormality that's going to point, an entire direction wrong. All right, abnormal breathing. So, conditions that impair gas exchange, increased space between alveoli and pulmonary capillaries, lack of perfusion of the pulmonary system from the right part, fluid, blood, or pus in the alveoli. So this is how we're talking about once oxygen gets down into, let me draw it over here. So we've got airway, and then we've got the lungs.
Can you get another marker?
What's that?
That marker's not showing up real good.
No?
I can't even see it with my glasses on. Oh yeah, here we go.
All right, so got the airway, the lungs, so here in the actual alveoli, it's going to be a whole bunch of little sacs. Excuse me, I'm a terrible drawer, but so what's going to happen is that the airway is going to come down into here, and the airway, the oxygen is coming to here and into these little sacs, and down here in these little sacs is where you're actually going to have the exchange from the oxygen. The oxygen is going to go into, so you've got capillaries all along these edges.
It looks like a bunch of grapes,
Yeah.
kind of, sort of.
So the oxygen needs to get down into here, and it's going to pass the oxygen into these capillaries, and then from these capillaries, it's going to pass carbon dioxide into there. And then it's going to be breathed out, and that's how we get rid of the carbon dioxide. So for this system to work, a couple things need to happen. The oxygen needs to be able to get down, which is the ventilation issue. So if we're not ventilating, and then naturally it's not able to get down and hit the major part. But let's say the oxygen gets into here and there is something that's blocking the pathway, not letting the oxygen actually get to these capillaries. Let's say this is filled with water or pus. So the oxygen's gonna try and come in, it's not able to reach it. So then the oxygen isn't able to get into the capillaries. So we're not able to get blood into the rest of the body. I'm sorry, oxygen into the rest of the body. We're not able to get the carbon dioxide out. Now, let's say that something happens and that makes the alveoli clamp up. All of a sudden, this alveoli is like that. The oxygen comes in and it can't get in there. The alveoli is closed. So now, again, you still can't get the oxygen in, you still can't get the carbon dioxide out, and so then the O2 just kind of hangs out and then shoots right back out. It's completely useless. That's an oxygenation issue. Does that make sense? Does that make sense how a ventilation issue and an oxygenation issue are different? Does that make sense how you can have a ventilation, your ventilation can be fine, but your oxygenation cannot work? Does that make sense? So something else that can happen that we're going to get into that talks a little bit about here is lack of perfusion of the pulmonary system from the right heart. So have you guys gone over the anatomy and physiology of the heart?
We've hit on it. We've not hit cardiology yet.
Okay, all right. So I won't dig too deep into it now, but right now we're talking about if oxygen can't get into here to get to the capillaries. But sometimes there's an issue where there's no blood. The oxygen will come in, the oxygen is ready to transfer, but there's no blood there. And so that's where we see situations like pulmonary embolism that we'll talk about later, where there's a blockage on more sort of, it can be actually in the lungs or in part of the heart that's not letting this blood come in to collect the oxygen and get rid of the carbon dioxide. Does that make sense?
Yes.
With cardiology, you guys will go more into it, but unfortunately it's something that they want me to talk about right now. So, fluid, blood, or pus in the alveoli. That's what we talked about, something sort of stopping up the alveoli. It doesn't matter what is actually in there, it's all gonna have the same issue. It's not gonna allow the oxygen to transfer or the carbon dioxide to transfer out. So that's why I'm saying that it's great to, learn all specific diseases, but a lot of diseases can have that symptom. A lot of different fluids can be present there, and they're all gonna have the same symptoms. It's all gonna cause the same issue, which is an oxygenation issue. So, listening to breath sounds. Have you guys practiced this at all?
No.
All right. Does everybody have their own stethoscope now? Good. Good. So this is something that, have you guys been practicing taking vital signs on everybody?
Not really.
Why not?
We're gonna start that tomorrow.
Oh, no, we,
No, y'all have done it, but we're gonna be more in lab tomorrow because I'm not gonna have to do this lecture tomorrow. I can upload it to Canvas and we can go straight to lab and do everything.
oh, no, I get it. When I talked to him last time, I just really stressed at home.
Yeah.
Yeah, I've been doing
Oh,
that.
we're practicing at home, it's really not here.
Oh, yeah. Just because, like I said, that's going to be really important. But listening to breath sounds is something that we're going to add to your toolbox. So, how do you think you listen to breath sounds?
Put the stethoscope here, on the back,
On the sides.
on the sides.
Yeah. So we try to go for a very systemic fashion. So, how many lobes? How many long lobes does everybody have?
5.
That's right. How many on each side?
2 on the heart side and 3 on the
That's right.
right side.
Your wife's been helping you? Yeah.
A little bit.
Yeah.
Thanks, homie.
Yeah, so you've got 2 lobes on the left, because also you've got the heart on that side, you've got 3 on the right. But a lot of times we talk about, upper lung sounds, lower lung sounds. A lot of times so you always want to do it, sort of in a systematic way. If you listen on one side, you need to listen on the other. So what you're going to be doing is to listen to upper lung sounds, you're going to find the clavicle, collarbone. You're going to find the mid-clavicular point. So you're going to take the clavicle, go halfway through the clavicle, you're going to go right below. And that's going to be your upper lung sounds. So understanding the mid-clavicular point is going to be very important. That's later on when you become medics so it's just important to start recognizing what's mid-clavicular, what's mid-axillary. So that's mid-clavicular. You listen to upper lung sounds. What you do is you put it, you can just drop down, an inch, maybe 2, and then you tell the patient to take a deep breath in and out. If they did one breath and you could actually hear it, great, and you don't feel like, say you heard something weird, you want to listen to it again. All right, take 2 breaths for me, in and out. Again. All right, if you listen to one side, you gotta listen to the others. You don't want to listen to one side entirely and listen to the other side entirely, because you need to be able to compare the sides. So deep breath in and out. Go to the other side, in and out. Oh, right side sounded a little bit diminished compared to left. Oh, well, I can just go back, listen again. All right, so that's upper. Now going down to, if you wanted to use sides, so we've got the mid-axillary line. So what you do is you just go down along the armpit. You can sort of listen down here. Again, on the side. Now to listen to lower lungs, it's really best to listen on the back. And what's nice about listening on the patient's back is that you can really start all the way from the top. If you're able to get to the patient's back, you can listen from the top all the way down. You can listen to upper, middle, and lower. So you think about it, you don't want to do it from the front because you might have a lot of tissue. You've got, the heart in the way on the left side. But listening to lower, you really want to be listening on the back. We call it mid-scapular line. So you find, you find the scapula and you can just work your way down. Again, left side, right side, left side, right side. The one thing I am going to warn you about is that if you're telling a patient, if you're going to listen to lung sounds in every spot, the total is supposed to be like, you listen like 16 spots. You tell a patient to take deep breaths, 16 times 2, 32, they're going to get a little dizzy. And they're going to tell you, like, I feel dizzy, because they're breathing out all this carbon dioxide. You tell them to take these huge breaths. Well, starting out, it's going to be, very important that you not only learn what abnormal breaths sound like, but also what just normal breaths sound like. Sometimes you're going to listen, you're not going to hear very well. Okay, you don't hear what put on one breath. Double check your stethoscope, make sure it's clicked on right, readjust. And what's great about working with partners is if you hear something kind of weird, have your partner, hey, left side sounds kind of weird, take a listen for me. Okay, no problem, that's what partners are for. If you ever have a patient that has weird lung sounds or has any sort of respiratory emergency, you need to be listening to their lungs. That is non-negotiable. That is not acceptable to not. Because it'll also really kind of clue you in. Oh, this patient's, having trouble breathing, but their lungs are completely clear. That's kind of strange. Well, then, we know their alveoli are kind of stopped up. Well, okay, they say that they've had a cough and, I hear crackles throughout. Ooh, do they have heart problems? It can clue you in a lot of ways. It can really let you figure out how, where it can really narrow down your issues.
And not only that, a silent chest is a big indicator of a lot of things. That's why you need to know what's normal, what's abnormal, but you need to know it's bad when you don't hear anything.
Have your patient sit upright and use the diaphragm end of your stethoscope over bare skin. Don't do it over close. It's lazy. There are times in emergencies that's what you have to do, but do it over bare skin. Tell them it's going to be cold. I don't care. Do it over bare skin. All right, auscultating the chest. So like we said, mid-clavicular line, drop down. give it a listen. The reason why you really need to practice a lot is because you are going to learn, with your own stethoscope. Every stethoscope is different. You're going to learn that if you hold it a certain way, then you're going to hear your finger rubbing. How you need to hold it for your stethoscope, and that's why you just really need to get into the practice. There's the mid-axillary line.
I usually put my fingers on each side, and
Yeah.
and that way it's not. That's just me.
Yeah,
Like
like
picture?
Yeah.
yeah,
like
exactly like in the picture.
Yep.
Like for mine, I actually have to hold it here because I've learned that if I put my fingers on the side, all I hear are my fingers scratching.
Mm.
So everybody's got their own stethoscope. Every stethoscope is a little bit different. There's the mid-axillary line. There's the mid-scapular line. That's where I was showing you that mid-scapular, you can go all the way from top to bottom. But, listening to a patient's back isn't always super easy, especially if they're strapped down on a board or something like that. You can't just listen to their back. So sometimes all you're gonna get is their front and their sides. I'm not gonna break somebody's balls over, I should have listened to their back. Yeah, it's ideal, but sometimes you're just not able to. So, abnormal breath sounds. So, wheezing, bronchi, and crackles. Let me find some sounds for you.
That's what I was just doing.
Yeah. So first let's talk about wheezing. So, does anybody know what that is?
Oh, yeah.
Yeah, everybody's kind of familiar, right? Everybody's got a friend with asthma, right? So, does anybody know what wheezing indicates?
The airway closing.
Yep. So a constricted airway. So a lot of times we are going to see this with asthma. Let's see. Alright, and how do I get the sound off of these?
You might have to turn the soundboard specifically up.
Oh yeah?
You might have to, but I don't know.
Is it playing on yours?
No. Speakers. Oh god. Good. Let's see if we can find another one.
Is that really what it's gonna sound like?
Can you listen to it? But also, so I mean, there's wheezing that you're only going to hear when you listen, and then there's wheezing that you are going to walk into a room and you're going to hear them.
You can hear them across the room.
Yeah.
You don't even need a stethoscope.
Yeah, and that's the real oh shit patient. Well, actually, technically, it goes.
The silent chest is
Yeah.
the real.
In this video, you is mucosal edema information. This cyclopedia flow. Notice that this actually means that now would be a good time to talk about stroke.
Now is every single one of them.
You can get knocked off your path and blaze a new trail forward.
That's the same one. You liar. So it's going to be this high pitch, and you know, if you really think about it, it's being caused by a constriction of the airway. So it's going to be any disease process. It's going to cause, you know, constriction, whether it be asthma, whether it be pneumonia, whether it be COPD, anything that can be causing a constriction of the airway can be causing some wheezing. You can have wheezing in conjunction with other lung sounds. So wheezing, you know, is, so we talked about, you know, you can hear it just with, when you're just listening, you can hear it from across the room, but she's right. So what's scary about, and this will probably be on a test somewhere in your life, where you have a patient that was wheezing really bad, you give them a medication, and then afterwards you can't hear it. You listen to the lung sounds again afterwards, and you can't hear anything. That's really bad, because that's what we call silent chest, which means then that, you know, before the airway was constricted, now it's just completely blocked. So that's why, you know, when we say silent chest is deadly, that's what we're talking about. So if you think about it, if you've got somebody who's wheezing, they've got a constricted airway, we need to give them something to open that airway up. So that's why we're giving them things like these nebulizers or the inhalers. People with asthma, the little inhalers, it's a medication, a beta agonist, albuterol, is a medication specifically designed to open up the airways. That's all it does. We're gonna get into that in a little bit using those. Next one is bronchi. Has anybody ever heard of bronchi before? So bronchi is when the difference between bronchi and crackles is very minute, and this was something that I beat my butt over for a really long time, the difference between them. In the end, they can sound almost identical. The difference really between them is that bronchi is that there's pus, or there is some sort of, you know, thick liquid that's sort of blocking up some of the pathway. And crackles is that it's like really thin, a lot of times, you know, thin fluid that sounds like bubbles.
It's like blowing through a straw in
Yeah.
a glass. It just kind of bubbles.
Yeah. So, you know, in the end, knowing the difference and being able to differentiate bronchi and crackles, it's a great party trick, but what's going to be most important is being able to recognize when you hear something just isn't normal. I don't care if you tell me you got bronchi. I don't care if you tell me you got crackles. If you say, you know, lung sounds just aren't right, there's some junk in the chest, something blocking, I don't care if it's bronchi or crackles or fine crackles or thick bronchi. The difference between them, especially listening to them, is just so minute that even, like, they're even arguing that the difference between them is so inconsequential that they're talking about even getting rid of the classification of bronchi.
Good to see you. Hey, what's with the polka dots? What do you mean? Polka dots are out.
Doesn't that sound exactly like blowing a straw through water? No. Rude. So you can have fine and you can have coarse. So here's how I remember. rayos. So crackles is also called rayos, which is just bubbles. That's the way I'll never forget the first time that I ever listened. I was an EMTB like 10 years ago, and we had a crashy patient, and the medic was like, listen to the lungs. And I listened, and in the heat of the moment, you can't think of like medical terminology, and I was like, I've got bubbles. She's like, bubbles? And I was like, bubbles. And since then, she just called me bubbles, but bubbles, crackles, rayos. That's just how I remember it. That's how it sticks in my mind.
Well, it's good to know I'm not the only one that comes up with things like that. If it works, it works.
It works, it works. If it's stupid and it's dumb, or no, if it works and it's dumb, it ain't dumb.
Exactly.
Here's it.
This to me sounds like a Tyrannosaurus Rex underwater.
And it's continuous.
So that's the thing, is that like the difference between gurgling and bubbles, when the patient has fluid or secretions, it's a pretty minute difference. If you're just able to tell that the patient's got bad lung sounds and good lung sounds. I mean, doesn't that sound like bubbles?
Kind of, yeah.
It looks like a really long expiratory time too.
Yeah. About to say, it's like the crackling sounds like maybe inhalation or exhalation, but this is like all the time.
Well, so
Yeah, I got that too. It's like it doesn't
It's like a
stop.
constant.
Yeah, constant sound.
Well, so both are continuous, because if you think about it, so large secretions or fluid in the alveoli, you're always going to hear that sound when you have air movement, whether it's in or out. If there's air moving, it's going to be passing through that fluid or those secretions. It doesn't matter whether it's in or out. So that's what we mean when we say it's continuous. Now, there are some lung sounds like wheezing or specifically wheezing that initially you're only going to hear on expiratory phase. So they'll be breathing in fine, but when they're breathing out is when you're going to hear the wheezing. And that's because the way that it's constricted, you don't have problems getting air in, you have trouble getting the air out. So you can see that with asthma, with COPD, all that sort of stuff. So it is very beneficial to be able to say, I've got, if you've got wheezing to start off, well, at first I've got wheezing only on expiratory, and then later on you've got wheezing on inspiratory and expiratory. And then it lets you know that you're heading down the wrong way. You're starting to run into more problems. But getting into the specifics, just if you just gotta start putting your stethoscope on chests. If your friend is sick, say, hey, here's some chicken soup. I'm ready for that for you. Let me listen to that chest. And I'm not even kidding. Flu season's coming. You gotta get practice doing this, and you gotta get practice doing it in a really controlled environment, so that when you're doing it on a shit show going 60 miles down the road, you can hear it. Does that make sense, everybody? All right. It's about 6:30. We'll take a 5-minute break.